In this presentation on the genetics of spinal muscular atrophy, I will discuss the role of genetics in the diagnosis of the disease, in carrier testing, the role of genetics in therapeutics, and also aspects of genetic counseling. The two articles shown on this slide illustrates the challenges faced by patients affected with spinal muscular atrophy and also the challenges faced by the family members of these patients. Spinal muscular atrophy is a leading genetic cause of infant death worldwide. The incidence of SMA is 1 in 6,000 to 1 in 10,000 live births. There are many subtypes of spinal muscular atrophy. The most severe form is known as SMA type 0. It develops before birth. The first sign may be a decrease or loss of fetal movement during late pregnancy. Symptoms at birth include severe weakness and hypotonia. One can also see joint deformity and tightening or contractures, and in some patients, even congenital heart defects. As a result of these conditions, infants do not achieve developmental motor milestones. Because of severe respiratory muscle weakness, affected infants rapidly progress to respiratory failure, often by the first month of life. Type 1 SMA, or the infantile onset SMA, is the most severe kind, affecting infants within the first 6 months of life. Some children with SMA type 1 will die before their second birthday, but aggressive therapy is improving the outlook for these patients. Type 2 or intermediate SMA develops in type 2, spinal muscular atrophy develops between 6 and 18 months. The child may be able to sit up, but respiratory challenges can shorten their lives as the disease progresses. In type 3 or juvenile SMA, the condition emerges 18 months or older and can become evident as late as even in teenage years. Muscle weakness is present, but most patients can walk and stand for limited periods, particularly early in the course of the illness. Type 4 adult SMA develops in adulthood. It's rarely severe enough to have an impact on the patient's lifespan. There is a form of SMA which is not related to the other 4 types, the other 5 types rather. It is not related because it is not the same gene that is involved. And it's important to distinguish this from the types 0 to 4, because most of the therapeutics involved in SMA is based on the involvement of a specific gene, which is the SMN1 gene. In this particular, this one shown here in this particular slide is not linked to that particular gene and has to be excluded when therapeutic considerations are being considered. So spinal muscular atrophy is caused by mutations in the survival motor neuron 1, which is located on the long arm of chromosome 5. So this is the gene that is involved in the typical form of SMA, which is the type 0 to type 4. And SMA, the pattern of inheritance of SMA is autosomal recessive. So any affected individual has to have two carrier parents. Both parents have to be carriers, and the risk of having an affected child is 25%, and the probability of having a carrier child is 50%. So it's a 25% of being affected offspring, 50% of having an offspring who's a carrier, and 25% of having an offspring who will not be a carrier. And this is the kind of information that has to be conveyed to the parents during counseling. So the SMA, the gene for SMA, which is the SMN1 gene, is located on the long arm of chromosome 5 in a region. It's a rather complex region where, in addition to the SMN1 gene, there's a pseudogene known as SMN2 gene. SMN1 and SMN2 differ by 5 nucleotides, one of which is in the coding region in exon 7. And this sequence change affects splicing, resulting in reduced expression of full-length functional protein from the SMN2 gene. So this slide shows how the exon 7 is not transcribed into the mRNA, and the protein is not functional. The one that is transcribed or produced by the SMN2 gene is a non-functional protein, whereas the protein produced by the SMN1 gene is a fully functional protein. So in individuals who are affected with spinal muscular atrophy, they have complete absence of the SMN1 protein is completely absent, and whatever is present is a limited amount of protein from the SMN2 gene. So typically people have 2 copies of SMN1 gene and 1 to 2 copies of the SMN2 gene in each cell. However, the number of copies of the SMN2 gene varies, with some people having up to 8 copies. In individuals with spinal muscular atrophy, having multiple copies of SMN2 gene is usually associated with the less severe form of the condition that develops later in life. The SMN protein produced by SMN2 genes can help make up for the protein deficiency caused by the SMN1 gene mutation. So this is why, depending upon the number of copies of the SMN2 gene, there is a variability in the phenotype of the patients. So in the type 0, there is usually only 1 copy of SMN2. So none of the types will have any copy of SMN1. But type 0 will have only 1 copy of SMN2. Type 1 will have 1 to 2 copies of SMN2. Type 2 will have usually 3 copies of SMN2. Type 3 will have 3 to 4 copies of SMN2. And type 4 will have 4 or more copies of SMN2. So the more copies of SMN2 an individual has, even in the absence of the SMN1 protein, the severity of the disease will be much less severe the greater the number of SMN2 copies you have. There are other unknown factors also that can contribute to the variable severity of the spinal muscular atrophy. So shown here is, on the top you have a normal individual with 2 copies of normal copies of SMN1 and 2 copies of SMN2. In individuals with the type 1 SMA, both copies of SMN1 are deleted, so all that individual has are 2 copies of SMN2, so there's a very limited amount of protein produced. In individuals with type 2 SMA, One copy of the SMN1 is deleted. The other copy of SMN1 is converted, goes through a gene conversion and becomes an SMN2. So that individual will essentially have 3 copies of SMN2. In type 3 SMA patients, both copies of SMN1 goes through a conversion and becomes SMN2. So those individuals will have 4 copies of SMN2. So a patient with SMA type 3 will have 4 copies of SMN2, and so the severity of the disease will be less compared to even a type 1 where there is only 2 copies of SMN2. So you can see how there is a correlation between the number of copies of the SMN2 and the phenotype. So with regard to therapeutics, motor neurons in the anterior horn of the spinal cord are extremely susceptible to the loss of the SMN protein. Due to the ability of SMN2 gene to produce small quantities of functional SMN, there are the therapeutic agents that have been developed are essentially ones that will enhance the production of the product from the SMN2 gene. So 2 of them are antisense oligonucleotides that target SMN2 to produce more functional SMN protein, and another one is a true gene replacement therapy. So one of the antisense oligonucleotide is administered intrathecally, and the other one is also a small molecule that again acts by promoting inclusion of the exon 7 in the SMN2 mRNA splicing, but that particular agent is administered orally. In the case of the gene therapy, it is an adeno-associated vector 9 mediated gene replacement therapy that can deliver a copy of the human SMN1, and it delivers the SMN1 transgene to the affected motor neurons, where it leads to an increase in SMN protein production. Because of the strong relationship between SMN2 copy number and disease severity, accurate and rapid measurements of SMN2 copy number are often used to identify treatment options and regimens for children with SMA. Accurate and rapid measurement of SMN2 copy number is particularly essential to guide decisions around timing and treatment choice for SMA infants identified by newborn screening. The impact of SMN hybrid genes and partial deletions on the responsiveness of these therapeutics have not yet been determined, but these atypical SMN genes are predicted to affect therapeutic efficiency, especially of the oligonucleotide agents, as they are dependent on endogenous SMN2. So if there is no SMN2 being produced at all, if the mutation is such that the gene is completely non-functional, these agents will not act in these patients. Another important factor to be considered when investigating parents for carrier status is that sometimes you will find that one of the parents is a carrier but the other is not a carrier, and that could be because of this of that parent being a silent carrier. A silent carrier is an individual where the normal number of copies of the gene are present. So in this case, SMN2, there are 2 copies of the gene, but both copies are on the same chromosome. So if the chromosome that does not carry the SMN1 gene is transmitted to the offspring, that offspring can potentially be affected. So when you test a silent carrier, the silent carrier will not appear to be a carrier, but in fact they are a carrier and is at an increased risk of transmitting deleted gene to the offspring. So this is something important that needs to be kept in mind when doing carrier testing. So to recap, incidence of SMA is 1 in 6,000 to 1 in 10,000 live births. The carrier frequency is about 1 in 50, which is quite high. And the dependence of severity of the condition is dependent on the number of copies of the SMN2 gene. The molecular characterization for SMA is feasible and it's available. Treatment is dependent on genetic characterization, including the number of copies of the SMN2. So as you can see, genetic characterization is very important in not only determining the severity of the disease, but also in determining if the patient is a good candidate for therapeutics. And carrier screening is very important because of this very high carrier frequency and the severity of the disease. And although therapeutics are available, it can be expensive. When performing testing for carriers, one has to keep in mind the aspect of silent carriers, because silent carriers can be missed when doing these carrier testing. There's plenty of informative literature available on websites. Genetic counseling is very important to educate the family and the parents on the pattern of inheritance, on the availability of genetic testing and prenatal diagnosis, so that they can take advantage of all that is available based on what their risk is. Again, all this has to be made available to the entire population, irrespective of socioeconomic status. So equity in management and therapy, in clinical intervention, and also in access to counseling and testing and treatment, because genetics does not differentiate between socioeconomic groups, so it has to be made available to all. Please send your questions, comments, and suggestions to the email address shown on this slide. Thank you.